Hello, this is Dr. Patricia Coughlin. In my last video, I was talking about the repressive process and the kinds of intellectualizing defenses that patients use in order to repress and avoid the experience of their anxiety-provoking, guilt-laden feelings and fantasies. In this video, I want to talk to you about the other category of defenses, the regressive defenses. These are defenses like acting out, dissociation, denial, projection. Some people call these immature defenses. They're obviously less adaptive than the repressive defenses, which actually have some benefits. I mean, they actually work in many cases to avoid experience of anxiety and painful feelings, but regressive defenses don't have that adaptive quality. They actually end up making the patient's distress even worse, right? By projecting unacceptable feelings onto others, the patient is then afraid, right, of others. Or if somebody is dissociating, right, they can hardly adapt to life in a productive manner. Now, one of the most important things when you're assessing the nature of defenses, again, whether they're primarily regressive or repressive, is to assess what is the baseline, right? So Davenlu talked about different levels or orders of defenses, lines of defense, if you will. So you might have a patient who comes in and they're rationalizing and minimizing. And as you begin to challenge that and to pressure the person for specificity, pressure them for the genuine experience of feelings toward the people involved, then they might suddenly go to projection. So in that case, again, the person has some capacity to mentalize, to think about things, to rationalize and minimize. But under pressure, as anxiety rises, they regress to using much less adaptive defenses. Now, that's a different clinical picture than a case in which projection is their first order of defense. And that's, in a sense, the best they can do. In that case, the individual has a much more fragile and primitive ego structure than the person in the first case. This is extremely important. I'm seeing trainees assessing a patient based on one data point, that someone got a little dizzy and dissociated for a minute, or projected in a particular situation. And they'll take that one data point and say, this person has a fragile character. Well, there's a lot more to it than that. And again, as long as the person has the capacity to mentalize, to rationalize, to displace, and so on, then they have that capacity, and you want to operate with them at their highest level of capacity, blocking regression. And that's very different, again, than someone who has a truly fragile structure and that only has regressive defenses at their disposal, in which case you're going to have to build capacity. So make sure that you're distinguishing between these first, second, and third sort of lines of defense, and whether the person is truly fragile and needs capacity building, or whether they regress under pressure but have higher capacity. You're going to work with those two groups of patients differently. Okay, so I hope that distinction is helpful. If there's any confusion about this or you have other questions, please leave me a comment or a question and I'll do my best to respond to that. Thanks. See you next time.